one of the things that we find when we work with nurses or physicians is that they see motivational interviewing, they hear about it, and they say, well, that's easy. I'm already doing that. I'm patient-centered. I listen. I understand my patients are ambivalent. I'm doing these things. How do you respond to that?
Well, I think that there are some people that have intuitively gravitated towards an approach that works. And if they truly are embracing an approach where their patients have a good response, then I think that's wonderful. I don't think that you necessarily have to have formal training. All too often is what I have learned, however, is by listening to recorded sessions that very often what feels like perhaps a client-centered approach to the practitioner is actually still their agenda, and they're still telling and pushing and prescribing, and you actually can hear what I like to call the worst-case scenario.
Can you tell me some more about that worst-case scenario? I'm intrigued by that.
Well, and you mentioned resistance before, and they're related. Through our clinical research, what we have found is that the practitioner can actually elicit what we call counter change talk, and they can actually elicit resistance by putting on the expert hat and prescribing and fixing and pushing people when they're not ready for it. And that I like to call it the yeah but dance, where you give someone advice and they go, yeah, that's nice, but. And it could even be a pleasant exchange. But the more we have that resistance, where the patient is telling you why they can't do what you want them to do and why it won't work for them, and showing their ambivalence in that way, and the practitioner keeps arguing for the change, that's actually the worst case scenario. And it correlates with poor clinical outcome. So it's definitely something that we want the practitioner to learn to recognize and to avoid.
I've been following this, the research on adherence, and from some of the studies that have been published in pharmacy and other specialties, it's indicated that physicians have no more than chance odds of predicting which patients are adherent, which patients are non-adherent, which just amazes me. Yeah. And it seems to me as if we had a good partnership model and we move from that patient education approach to that dialogue and evoking ambivalence, that could be reduced, that accuracy of predicting who would be adherent and non-adherent could be increased. And also the fact that one of the cardinal warning signs of non-adherence is overcompliance. So I'm thinking about that yes but statement, and we all have the patients that they come in and we have a brilliant insight, and we think, boy, that was great, and they agreed, they said, wow, I'm going to go out and do this. And maybe they're the ones that are least likely to be compliant. What's MI's take on that?
Well, it's along those same lines that it's one of those ironic things that even though we're experts, our insights and our experience doesn't nearly have the same impact on the patient as if we pull out from them their own realizations about the benefits of change, that they're able to work through some of the barriers that have been holding them back, and that they actually identify their own plan and their own support. They're much more likely to follow through.
So the standard patient education approach would not evoke that kind of talk?
Absolutely not. In fact, there are many times where we find that the traditional patient education model actually is evoking that resistance where the person is not ready for information or advice, or a lot of times they've been told the same thing 20 times and they start to roll their eyes and tune the professional out. And again, not only is that neutral in evoking change, but it's actually doing harm. It's a predictor of poor clinical outcome.
And particularly for people with limited health literacy or from a different culture. They may already come into that situation not understanding what they need to do, and each time are provided instructions about what they need to do, and some of the cultural factors might not be addressed or adapted for that person and what's meaningful in their day-to-day family life?
Well, it's certainly important to have that fluency in cultural differences. And with motivational interviewing, it does cross cultural boundaries because it is so client-centered. And I don't want to imply that there's never a time and a place for education and advice. It's just that all too often that is our total prescription, and we haven't primed the patient. In other words, we haven't helped them become ready and motivated and receptive to that advice and that information. And so really it's a waste of everybody's time.
And it seems like there's an aha moment when healthcare professionals begin to see, now I understand why I feel so frustrated. Now I understand why the patients I'm working with aren't taking certain steps or taking their medications. That it puts a lot of pressure on me as a provider if I feel as if I have to take something and install it in somebody's head and change them. That's overwhelming.
Yeah.
And we see a lot of nurses that simply burn out because they don't have a step-by-step process. They don't have the data to tell them whether they're being successful, and they're not sure. So we found that it's really important to give nurses and other professionals some guidance on the evidence-based steps that they can take so they're healthier in their own lives.
Absolutely. It's frustrating for healthcare providers to enact their training. I mean, they've been taught in school to take this traditional patient education approach and then to find that it doesn't work. And it is frustrating. And so I think one of the fringe benefits of training staff in this approach is that you end up with individuals who have a much more optimistic view about change. They're having more successful encounters. They have better job satisfaction, less burnout, less cynicism, and they simply enjoy their job more.